Hello students, in this video I will be covering the drugs for the congestive heart failure. So if you have seen my previous video, in the previous video I have covered what is the heart failure, what are the important causes, and the most important is myocardial infarction. What are the various types of heart failure like acute, chronic, right failure, left failure. Then we have a forward and a backward failure, systolic, diastolic, low output and a high output failure. Then pathogenesis of both acute and chronic heart failure. Then treatment of acute and chronic heart failure. So acute heart failure, this I have covered in the previous video. So if you haven't watched that video, I will be giving a link in the description box. You can go and watch that video. Then treatment of the chronic heart failure. Under this, the aim was to decrease the cardiac work. इसमें ये है to decrease the cardiac work. We put the patient on vasodilator. This also I have covered. Then to decrease the edema, if it is there, we give diuretics. Again here, the diuretic furosemide that is used. To increase the cardiac output, if it is needed, we give cardiac glycosides. So these are going to give the symptomatic relief. They do not have any survival benefit. So they are the certain drugs which are going to improve the survival of the patient. So to improve the survival of patient, that the group of drug they are beta blocker. Then we have angiotensin converting enzyme inhibitor. Then we have angiotensin receptor blocker. And then we have aldosterone antagonist. So these are the four groups which are going to improve the survival of the patient. Now this I have covered. इसमें ये वाला आपका vasodilator, this is covered, this is covered. So in today's video, the rest of the drug along with that, the newer drug will be covered. Now coming to the cardiac glycoside. What are the cardiac glycosides? They are also going to increase the cardiac output by improving the contractility. But how they differ from the cardiac stimulants? They are the two drugs. One is cardiac glycosides, like which I am going to take today, and another one is a cardiac stimulant, which you read under autonomic nervous system also, like adrenaline. So cardiac stimulant and cardiac glycoside, they both of them, they have positive inotropic effect. They are going to increase the contractility of the heart, but the difference is cardiac glycoside, they do not increase the oxygen consumption of the myocardium, whereas cardiac stimulant, they are going to increase the oxygen consumption. So under cardiac glycosides, what all come? Cardiac stimulant में आपका क्या आता है? Cardiac stimulant में we have adrenaline. So under the cardiac glycosides, we have the main drug is digoxin and digitoxin. Earlier even हुआ बहन. So all the three, they are obtained from the plant source. But nowadays, out of these three, the clinically we are using only digoxin, and from where it is obtained? Digoxin, that is obtained from the digitalis lanata. This is from the digitalis purpurea. Okay. Now it is a glycoside. So this is a important. What is the structure of this cardiac glycoside? It consists of A glycone part. ये इतना जो है, this is a A glycone part. attached with the sugar moiety, that is the glycone part. और a glycone part क्या है? That is a steroid ring. You can see the steroid ring along with that unsaturated, इसके नीचे लिखा हुआ lactone, that is a steroid ring along with that unsaturated lactone, that is one. Another glycoside you can remember like aminoglycosides. इसमें भी यही है, unsaturated lactone ring they are there. Now important is, which is very commonly asked in the MBBS exam paper, what is the mechanism of action of digoxin? It is very important question here. So how the digoxin they are going to act? Now cardiac glycoside, what they are going to do? What is their action? They have positive inotropic action, means they are going to increase the contractility of the myocardium. Myocardium की contractility, how it is done? How myocardium it contracts? What is the mechanism? So first you must know how normally this myocardium it contracts. This is suppose myocardium. This is a wall, myocardial wall. This is a myocardial cell. So normally, which ion is responsible for the contraction of the myocardium? It is the calcium ion. So calcium it enters within the cell. Now, once it enters in the cell, this is the one which is going to stimulate the ryanodine receptor which are present on the sarcoplasmic reticulum. ये आपका myocardial cell है, समझ लो. This is a myocardial cell, and here are the ryanodine receptor 2. So they are going to trigger this one, and there is a release of huge amount of the calcium from here. So this enters and it is going to cause a release of massive release of calcium ion from the sarcoplasmic reticulum. Now this calcium, what it is going to do? It is going to cause the activation of actin and myosin, and ultimately what will happen? The muscle will contract. Now after the contraction, now what will happen to this calcium? From where it has come, the cell is going to send that calcium again to the same site from where it has taken. Suppose from the outside, from this L type of, here it is a L type of channel. Okay, this is a L type of the calcium channel. Suppose from here the 100 molecule of the calcium it enters, and from the sarcoplasmic reticulum it is the 1000 molecule of the calcium they are released. So कितने आप हो गए? 100 plus 1000, it is a 1100 molecule. They are going to cause the contraction. What will happen after the contraction happens? Then this 1000 calcium molecule, they will be taken up back by the sarcoplasmic reticulum by another pump that is called, it is called SERCA. It is called SERCA, SERCA. Now what is this SERCA? I'll expand here. SERCA. This is sarcoplasmic reticulum. Yes, sarcoplasmic endoplasmic reticulum. Calcium ATPase. This is the pump which is here, and this is going to bring back this 1000 molecule of the calcium again back to the cell. Now remaining that 100 molecule जो यहाँ से आपके enter हुए, which comes from here, where it will go? it will be removed by the cell with the help of sodium calcium exchanger. सोडियम will move inside and calcium will move out. ये आपका कैल्शियम गया और ये आपका सोडियम अंदर आया with the help of sodium calcium exchanger. Sodium for N, calcium is C, exchanger is X. Now sodium moves inside and calcium moves outside. Now again, sodium has entered inside. Now this sodium, it will be removed with the help of what? With the another pump, that is sodium potassium pump. So potassium will come inside and sodium will move out by the sodium potassium ATPase pump. Okay. So this is how the normal myocardium it contracts. Now what happens when we are going to give the digoxin or cardiac glycosides? So digoxin, what it does, number one, it is going to bind with this sodium potassium ATPase. Digoxin, it is going to bind here and it is going to inhibit this. This is the number one. So digoxin binds with सोडियम पोटाशियम ATPase. ठीक है, ये इतना याद रखो. Now again recall whatever, leave this step last one and recall how exactly happened. This calcium, it enters through the voltage gated L type of calcium channel. It is going to trigger the release of the calcium from the sarcoplasmic reticulum by the stimulating this ryanodine receptor. Huge amount of the calcium it is released, which is going to cause the contraction of actin and myosin, and ultimately the myocardium it contracts. Then what will happen? This calcium it will be reuptake by the sarcoplasmic reticulum with the help of SARCA, and the calcium which has entered through the L type of the calcium channel, जो आपका यहाँ पे enter हुआ था, that amount it will be exchanged with the calcium by sodium calcium exchanger, and then this sodium which has entered within the cell intracellularly, the balance is restored by activating sodium potassium ATPase pump. Okay? Now, once the digoxin binds with sodium potassium ATPase, now what will happen? The sodium will not move out. Sodium will not move out. Now sodium will accumulate. Sodium accumulate within the cell. This is number 2. Number 3 is this. Calcium enters. It is going to trigger the ryanodine receptor. There is release of huge amount of calcium, which is going to cause the contraction. Then after the contraction, this is taken back by this sarcoplasmic reticulum, and few amount there will be exchanged with the sodium. But this step, which it is not going to happen. Why? Earlier the calcium it was moving out in exchange with the sodium. Now because the digoxin it has inhibited this sodium potassium ATPase, already the sodium it is moved within the cell. So this exchange, sodium calcium exchange, where the sodium is moving inside and calcium is going out, this will not happen because already the sodium ion it is present within the cell. So this, if the sodium is already there, it won't be get exchanged with the calcium. So where the calcium will go? Calcium will not go out. Now what will be the fate of this calcium? Instead of going out, what will happen to this calcium? It will move within this. It will move within this sarcoplasmic reticulum. Now earlier the sarcoplasmic reticulum, they released only 1,000 molecules of the calcium. Now this 100 which has come from the L type of calcium channel, they are also taken up by the sarcoplasmic reticulum. Now with the next depolarization, again same thing happen. There will be the entry of the calcium within the cell, and this triggers the ryanodine receptor. Release of now, अब इसकी जगह कितने होंगे? 1100 molecule of the calcium will be released, which is going to cause the contraction. Okay? If you have given the digoxin, then after the contraction thing happen, if it is not sufficient amount of the calcium which is released, then there will be no contraction. But what will happen? What will be the fate of this calcium, this whole calcium? It will again move within the, अब कितने गए? 1100. With the next depolarization, another 100 will be again enter through the L type of sodium channel. Then where this will be gone? To the sarcoplasmic, यहाँ पे जाएगा sarcoplasmic reticulum. And once the sufficient amount of the calcium level it is achieved within the sarcoplasmic reticulum, then what will happen? The cell, it is going to contract. Myocardium, it is going to contract. So you can see another illustration from the tripartite. Here it is very clearly shown. Digoxin, it is going to bind with the sodium potassium ATPase. It is going to inhibit this. Then what will happen after inhibiting this? From calcium, it enters to the L type of the calcium channel. Once it enters within the cell, it is going to trigger or activate this ryanodine receptor 2. See, ryanodine receptor 1, they are present in the skeletal muscle. Here in the cardiac muscle, it is a ryanodine receptor 2. And with the ryanodine receptor 1, which drug act? That is a dantrolene. So, again coming back to the mechanism of action of this digoxin, it is going to inhibit the sodium potassium ATPase. Okay. Then calcium enters through L type of the calcium channel, and this calcium, it is going to trigger the release of calcium from the sarcoplasmic reticulum by stimulating this ryanodine receptor. Now this calcium, once it is released, then what will happen? ये release हुआ आपका, it is going to cause the contraction of this. Once the contraction happens, then what will happen? This calcium, it is taken back by the sarcoplasmic endoplasmic reticulum, calcium ATPase. This is taken up by this. Okay? So whatever amount has entered with the L type, it will be exchanged with sodium calcium exchanger. And once this calcium, it moves outside and sodium moves inside, then what will happen? Normally this sodium moves out, whatever has entered with the sodium calcium exchanger, this will move out and potassium will enter inside. Now because digoxin, it has inhibited this sodium potassium ATPase, so sodium ion already it is more. So this exchanger, this sodium calcium exchanger will not work. ये वाला भी काम नहीं करेगा. It is going to inhibit this. This will also not work. What will happen? No, the sodium will not come inside, calcium will not move out. So instead of moving out, this calcium, it will be also taken up by the sarcoplasmic reticulum, and with the next impulse, जो आपकी next impulse है, the more amount of the calcium will be released from the sarcoplasmic reticulum. This is how digoxin it acts. It is very important, very important question in the MBBS paper. Write the mechanism of action of digoxin, how it acts in a CHF, or digoxin in the CHF. So you are supposed to write all the steps, and then try to, if you can draw the diagram, if you can memorize, it will be easy to write. Now after this, what are the pharmacological action of this? Now it is going to increase the contractility. So definitely heart पे क्या होगा? By increasing the contractility, it is going to improve the cardiac output. So especially this drug is effective once if you have put the patient on angiotensin converting enzyme inhibitor or ARB plus minus beta blocker, and if the person's cardiac output is compromised, of if there is a systolic dysfunction, then this is the drug to be given along with that. So it is going to increase the contractility. By increasing the contractility, it is going to improve the cardiac output. Once the cardiac output that is improved, अगर आपका cardiac output improve हुआ गया, then what will happen? The tissue perfusion will improve with this. What happens? The tissue perfusion will improve, and with that, जो patient की tiredness थी, dyspnea था, that will be improved, and plus the renal perfusion improve होने से क्या होगा? There will be diuresis, work of the heart preload will be decreased, then pulmonary congestion that will be also released, there will be no dyspnea, no cyanosis. So cardiac output improvement से all the things because of the improved tissue perfusion, it is going to relieve the symptom of congestive heart failure. So earlier it was one of the main drug which was used for the treatment of the heart failure, but nowadays it is not the main drug which is to be used for the heart failure. They are the important reason because of its low margin of safety. Number one, this, and number two is because it does not give any survival benefit. It is only giving a symptomatic treatment. It is only going to give relieve the symptomatic treatment. So no survival benefit that is achieved with this drug. Third one is its important toxicity. Low margin of safety, that is already important adverse effect. ADR, that is very important with this group of drug. So because of these reasons, this drug, it is not the primary drug. I will be taking what are the important adverse effects which are shown by this drug. Blood vessels पे ऐसे कोई खास नहीं है. With the normal people, if we are going to give, it is going to cause the vasoconstriction, but it is improved if the person is having CHF. अगर आप digoxin देते हो with the CHF, then it is not going to cause the vasoconstriction. Kidney में diuresis, that is the main. GIT में mainly not much effect, because of the CTZ center in the CNS stimulation. Patient will have nausea and vomiting, which is very important side effect. One of the important side effect with this is a nausea and vomiting. So important where we are going to other important pharmacological action in the heart. एक तो ये हो गया ना कार्डिक दिस थिंग. So where we are going to use apart from this, another important pharmacological action is it has got vagomimetic action. Now what is a vagomimetic action? Vagomimetic action is it is going to decrease the heart rate. This is another reason why we are not using this drug, because of this vagomimetic action, and it is going to decrease the conduction, and we do not want this effect in the heart failure patient. So where we are going to use this drug now, where the cardiac output is decreased because of the systolic dysfunction, and this vagomimetic action, where we can use this vagomimetic action of this in atrial fibrillation. Okay, so atrial fibrillation. So what is the atrial fibrillation? Here the rate of atrial rate in atrial fibrillation is 500 beats per minute. Okay? And in atrial flutter it is 200 to 350 beats per minute. Always remember one thing. So whenever the person is having atrial flutter or atrial fibrillation, it is always important we have to maintain the or control the ventricular rate. Okay? From the atria, all the impulses will go to the ventricle. From where? By the AV node. Okay? From the atria to the ventricle, how the impulses will be transmitted by AV node. Okay? If we are going to give the drug which is going to delay or which is going to inhibit the passing of the impulses from the atrium to the ventricle, like this drug digoxin, because it is delaying the conduction. Conduction kahan pe? AV node. So if it delays the conduction, all the impulses which have started from the atrium will not be conducted to the ventricle. So we can control the ventricular rate. So which one is more dangerous here? Atrial flutter, it is more dangerous as compared to atrial fibrillation, though the rate is more in atrial fibrillation. Why it is more dangerous atrial flutter? Because out of this 200 to 350 beats in atrial flutter, maybe the 250 beats they are passed to ventricle. So ventricle, it is going to beat at the rate of 250 beats per minute. Whereas in atrial fibrillation, the contraction is so febrile that all the impulses will not be passed. Maybe out of 500, it is only 150. They are going to pass from the atria to the ventricle. So digoxin, it is going to convert atrial flutter into atrial fibrillation. So where we can use this drug if the person is having congestive heart failure with atrial fibrillation. So this is the current status of the digoxin. We give digoxin if the person is having congestive heart failure with the atrial fibrillation. And second use is, it is used for the treatment of, for we can give for the atrial flutter and atrial fibrillation. इसमें हम दे सकते हैं. And the third thing is, we can use it for the paroxysmal supraventricular tachycardia, PSVT. इसमें हम दे सकते हैं paroxysmal supraventricular tachycardia. Otherwise, because the drug of choice here, it is a adenosine. Second one is, we can give verapamine or calcium channel blocker. Then this. So all these drug which we are using for the PSVT, they act by delaying the conduction through AV node. So this is the action on the heart. And what is the current status? Current status of the digoxin is, it is used in CHF with the atrial fibrillation. Now what are the important pharmacokinetic features? Because presently we are using only digoxin. Digitoxin use ही नहीं होती. So both we can give by parenteral and oral route with a good bioavailability इसकी है, and this is 40 to 60%. Here important is onset of action 15 to 30 minutes and half-life is 40 to 48 hours. So this is going to take 5 to 7 days to get the steady state plasma concentration. It is going to take 1 week. So usually we give a loading dose followed by, not usually. So if you want the early action, आपको emergency है, so you can give loading dose followed by the maintenance dose. Otherwise हम ये use नहीं करते. Another important difference with the digoxin and digitoxin, this get excreted by the renal. So इसको हम क्या करते हैं? Renal insufficiency में this is a contraindicated. This is metabolized in the liver. So it is contraindicated in any hepatic insufficiency or any disease. So you can see here, rarely used. पहले यूज करते थे, अब बहुत कम यूज करते हैं. ना कि we do not use it, rather not rarely. Rarely word भी ठीक नहीं, it is not used. So this is used, the only glycoside, cardiac glycoside which is used clinically, that is digoxin. It is used for the initiation. Initiation किसमें? जहाँ पे CHF it is associated with the atrial fibrillation, and maintenance is where the person is having CHF with the systolic dysfunction, उसका cardiac output it is not sufficient, that is, and where there we use digoxin. Then another important is its safety margin. So therapeutic concentration is, you cannot see here, 0.5 to it is 1.4 microgram per ml, and toxicity is if it is more than 2. So safety margin between the therapeutic concentration and toxic concentration, that is very narrow. So we have to give TDM, therapeutic drug monitoring, इस केस में हमें करनी पड़ती है. Now what are the important adverse effect? जब भी आप ये वाली drug देते हो, what are the important adverse effect of this drug? एक है extra cardiac and cardiac, and divide extra cardiac and cardiac adverse effect. Extra cardiac में क्या है? The most important and the earliest, most common and the earliest side effect, they are related with the most common and the, here I'll write word earliest. This is very important YOC question and very important MCQ. Earliest side effect with the digoxin, that is nausea and vomiting. So any patient, if you have put digoxin, complain with the nausea and vomiting, immediately stop the drug. ठीक है, साथ के साथ ही आपने उस पेशेंट की ये वाली मेडिसिन बंद कर देनी. Along with that, what are the side effects? Patient may have abdominal pain, may have a diarrhea. So with the fluid loss, you can remember, अगर fluid loss हो गया, then there will be restlessness, there will be mental confusion, there will be psychosis, all that related with the dehydration, all the symptoms will be, patient will be having all that. So extra cardiac is most common is the GIT. यहाँ पे GIT side effect, that is the most common. Now cardiac side effect. Cardiac side effect is because this drug, it is increasing the level of what? Calcium. तभी ये contraction कर रहा है ना. So it is going to cause any type of arrhythmia, because in the arrhythmia after depolarization and after early depolarization, after delayed depolarization, in most of the arrhythmia the mechanism is the calcium overload. इसमें तो वो कर ही रहा है calcium overload, calcium is increased. So any type of arrhythmia, so most common cardiac side effect is arrhythmia. और सबसे कॉमन कौन सा है? Ventricular bigeminy. That is the most common arrhythmia which is seen with the cardiac glycoside. इससे सबसे कॉमन जो है वो आपका ये वाला आता है, ventricular bigeminy. And now how you are going to treat with the patient? आप इसको कैसे ट्रीट करोगे? अगर पेशेंट को nausea and vomiting, stop immediately and go for the electrolyte. आप electrolyte देखते हो पेशेंट का, you measure the potassium level, you measure the calcium level, you measure the magnesium level. Usually patient will be having hypokalemia and आप क्या करो उसको? KCl, you infuse the KCl. ठीक है? And if the patient is having arrhythmia, समझ लो ventricular arrhythmia है पेशेंट को, give the lignocaine. Bradyarrhythmia, you give the pacemaker. ठीक है? But still, if the patient does not show any improvement, उसकी अभी भी नहीं है, उसको severe arrhythmia and everything, patient is not showing any improvement, then you give the digoxin antidote, that is Digibind. ठीक है? You are going to give the Digibind. Now how this Digibind? It is only FAB fragment, this is going to bind, and FC part is not there, so it is the non-immunogenic. Now important, you can say toxicity or drug interaction. What are the things which are going to cause the toxicity of this or enhance the toxicity of digoxin? एक तो आपके हो गए आयंस, जैसे कि डिक्रीज पोटाशियम, और यू कैन से हाइपोकैलीमिया. ये बड़ा इंपॉर्टेंट क्वेश्चन है. हाइपोकैलीमिया, इट एनहांसेस द डिजिटालिस टॉक्सिसिटी. Hypokalemia, even decrease magnesium that is also going to cause the toxicity and increase calcium. Now, why hypokalemia? It is going to cause the digoxin toxicity. Remember one thing, how the digoxin it act by binding with the sodium potassium ATPase. Okay, this is a sodium potassium, sodium आपका अंदर गया and potassium sorry draw single simple diagram. Sodium will move outside, potassium is intracellular, so potassium moves inside with the sodium potassium ATPase. Now digoxin it binds with this enzyme and it inhibits this. Now for this enzyme there is a competition between digoxin and a potassium ion. Now both they bind with this enzyme. If there is less potassium or if there is hypokalemia, then what will happen? There will be no competition between digoxin and potassium for this enzyme. If there is no potassium, there will be no competition between digoxin and potassium for the sodium potassium ATPase. Now what will happen? More amount of the digoxin will bind to the enzyme and it is going to cause the toxicity. So hypokalemia, it leads to toxicity of digoxin. But always remember, once the toxicity happens, एक बार अगर digoxin की toxicity हो जाती, then there is a hyperkalemia. So very commonly the students they get confused. Hypokalemia, it causes the digoxin toxicity. But once the digoxin toxicity happens, then there may be a hyperkalemia. Then why there is a hyperkalemia? If the toxicity happens, this digoxin, because of the toxicity, it is going to inhibit this enzyme. इसने क्या किया? It is going to inhibit this sodium potassium ATPase. एक बार ये enzyme अगर inhibit हो गया, then what will happen? The potassium will not be able to enter inside the cell. ये अंदर नहीं आएगा. It will remain outside. Then what will happen? There will be hyperkalemia. So hypokalemia, it is the one which enhances the toxicity. Elderly maybe this digoxin, it can lead to toxicity. Elderly may, if the person is having any renal insufficiency, any hepatic insufficiency, that can lead to digoxin toxicity. Then thyrotoxicosis, that can also cause the toxicity. Then another few important drugs which can cause the toxicity. They displace it or they decrease its clearance, like quinidine. Then we have a verapamil, diltiazem, amiodarone, and few drugs they delay the digoxin absorption and few drugs they increase the absorption of digoxin. So these are the important. इसमें सबसे important जो है that is a hypokalemia, and these few drugs you should try to memorize. So that's all about the digoxin. Now coming to this I have covered. Now how you can reverse the disease progression by giving this beta blocker. So we have to inhibit the RAS system. And what is the main stimulation for the RAS system? First one is a beta 1. Because of the sympathetic overactivity, what will happen? Because of the sympathetic overactivity, this beta 1 receptor, they are going to activate the JG cell. So यहाँ पे beta 1 blocker that is going to act. Then another one is a ACE inhibitor, then angiotensin receptor blocker, and last one is a aldosterone receptor antagonist. So all these group of the drug you must write, they are going to improve the survival by inhibiting this sympathetic overactivity. They improve the survival by inhibiting this sympathetic overactivity. Now beta 1. So usually what happens earlier, like in heart failure, if we go logically in a heart failure patient where the cardiac output is decreased and heart is not able to contract, if we give beta blocker, if we are going to give a beta blocker, then what will happen? It has got the negative inotropic effect. So logically, we should not give beta blocker to the heart failure patient. This was the earlier we used to ask why beta blocker, they are contraindicated in a heart failure patient. But nowadays, we are using beta blocker in heart failure patient. So earlier we used to write because it has got the negative inotropic action. So heart contractility will be hampered, so it is a contraindicated. But now what we write, because of the sympathetic overactivity, it is going to stimulate the RAS system, and because of that stimulation of the RAS system, it is going to cause a cardiac remodeling. So by giving the beta blocker, it is going to reverse the cardiac remodeling and it is going to improve the survival. Now where we are supposed to give this beta blocker? In acute heart failure, again here it is contraindicated. The beta blocker, they are contraindicated in acute heart failure. Why it is contraindicated? Because in acute heart failure, it is a decompensated heart failure. यहाँ पे अभी compensation शुरू नहीं हुई. The sympathetic overactivity, it is not started. So it is already decompensated. So if you are going to give a beta blocker, the person condition will be deteriorate. Condition of the patient will deteriorate. So in acute heart failure, we are giving the beta agonistic drug. Remember beta 1 agonistic drug in my previous video. So beta 1 agonistic drug, we are giving dobutamine. We are putting the patient on dopamine. So beta blocker, they are contraindicated in a acute heart failure. So even here also in a chronic heart failure, how you have to give? You have to start with a low dose. Why you have to start like in chronic heart failure or in compensated heart failure or in a chronic heart failure, you have to start with the low dose because we do not want this compensated heart failure to move towards the decompensation by giving a large dose, and slowly we are going to increase the dose. So these are the few things which you must remember when you are putting the patient on a beta blocker. So beta blocker, they are contraindicated in acute heart failure. In chronic heart failure, you have to start with a low dose and slowly you have to titrate and give it a higher dose. This is again very clearly, it is given as standard textbook of pharmacology. Triparty, you can go and read beta blocker in CHF, how we give and in what condition we are going to give, not in acute heart failure. It is only to be given in, यहाँ पे आपकी contraindicated है, in chronic heart failure we are going to put the patient on this beta blocker. And how they are going to? They are going to reverse the remodeling. They are going to improve the survival. Same way, ACE inhibitor. They are going to inhibit the conversion of angiotensin 1 into angiotensin 2, which is the main factor which is going to cause the cardiac remodeling and the person condition will worsen. So cardiac remodeling से क्या होता है? It is going to reverse inhibit the apoptosis and fibrotic changes of the myocardium. So it is going to improve the survival. And now the basic difference between ARB, किसमें आपने ARB डालना है, angiotensin receptor antagonist, because ACE inhibitor like इसमें क्या आपके आते हैं, sorry ऊपर जो रह गया आपका बीटा ब्लॉकर में what all drugs you can give? It is a cardio selective. You can give metoprolol, nebivolol, then one non-selective like carvedilol. This is a non-selective beta blocker. Along with it has got the alpha component also. So these are the beta blocker we can use in the chronic heart failure. ACE inhibitor में आपके क्या आते हैं? Captopril, enalapril, lisinopril. ठीक है, ये वाले सारे आते हैं captopril this under the ACE inhibitor. So how they are going to act? Now ACE inhibitor and angiotensin ARBs, they are losartans, ये आपके क्या है, दिस आर कैप्टोप्रिल, इनालाप्रिल, ये वाले हैं लोसार्टन, टेलमिसार्टन, इर्बिसार्टन, कैंडिसार्टन, ठीक है, ये वाले. Now what is the both they are going to this ACE inhibitor, what happens from the, if you are going to give this enzyme, it is going to inhibit the conversion of angiotensin 1 into angiotensin 2, but angiotensin 2 it is formed by other way also. If that is formed, that is going to stimulate this act on the angiotensin receptor. So if you are going to give the angiotensin receptor blocker losartan, then that is the final step. So more survival with this. Another thing is with ACE inhibitor, there are the certain side effects with the ACE inhibitor, like there is the accumulation of the bradykinin because it inhibits the metabolism of bradykinin. So that is going to cause the dry cough. There is the angioedema, then taste alteration that also happens with the ACE inhibitor. Then it is a phytopathic is there, and those side effects we can avoid with the angiotensin receptor blocker, with the losartan, telmisartan, this kind of drug. Then coming to the next drug, that is aldosterone receptor antagonist. Okay, so aldosterone receptor antagonist, again it is also going to give the same benefit, survival benefit, okay, by inhibiting the aldosterone receptor antagonist. What is this one? The main drug here is a spironolactone. This is the aldosterone receptor antagonist. This is the main drug, and this is also going to improve the survival by inhibiting the this cardiac remodeling, and it is a potassium sparing diuretic. Okay, so diuretic we are giving in heart failure. The furosemide, they are going to provide the symptomatic relief, whereas potassium sparing diuretic spironolactone, they are going to improve the survival. This is the basic difference between the two type of the diuretic. And spironolactone, इसमें important side effect क्या है इसका? This causes the gynecomastia. So we can put the patient on another aprinol. ये दे सकते हैं आप patient को. This is another aldosterone receptor antagonist. Now few points about the newer drug. Newer drug एक मैंने बताई आपको, synthetic BNP. That is nasiritide. Now what happens in the congestive heart failure, when there is a volume overload, whenever there is a volume overload, and because that is going to, जैसे ये है sympathetic activity, heart में क्या है, because of the increased sympathetic activity, then angiotensin, ये आपका AT, aldosterone, ADH, all these they are going to stimulate this heart, which is going to cause the stimulation of the stretch receptor, and there is a release of what, ANP and BNP from the ventricle. Now this atrial natriuretic peptide and a brain natriuretic peptide, इनके क्या action है? They are going to cause what? Natriuresis and vasodilatation. They cause a natriuresis, जो कि हमें चाहिए यहाँ पे, natriuresis and vasodilatation. But what exactly happened? Though there is a release of this, but in congestive heart failure, they exert the paradoxical effect. इसमें इसके साथ usually, though it is released, but we do not see these two type of effect. Second thing is this ANP and BNP, they are metabolized by neutral endopeptidase, NEP. They are metabolized by neutral endopeptidase very fast. ये आपका neutral endopeptidase, another name is neprilysin. Neprilysin. So they are going to metabolize. ये वाले हैं चाहे आपके this one, or you are giving nasiritide, synthetic BNP. This is also same effect. It is also going to produce natriuresis and vasodilator, and it is metabolized by neutral endopeptidase or neprilysin very fast. So we gave this nasiritide by IV route. That's why this nasiritide or synthetic, it is a short acting. We give it by IV route. It is used in acute heart failure. इसको कहाँ पे हम use करते हैं? We use it in acute heart failure. Now, if you want to increase the life of this BNP, half-life, which is very short acting, so how we can increase the half-life of this drug? By giving the drug which inhibit this neprilysin. तो इसको inhibit कर दे. Once we inhibit this, then what will happen? This won't be metabolized. आपका BNP won't be metabolized. It will remain for a longer time. Now, what is the drug which is going to inhibit this enzyme? We have a drug that is sacubitril. They are the neprilysin inhibitor. So they are going to inhibit the degradation of brain natriuretic peptide, and we use it in a advanced case of CHF. We use it in a refractory CHF. So sacubitril, that is a neprilysin inhibitor. And nowadays there is a one FDA approved combination of sacubitril is with sacubitril with valsartan. So what is valsartan? Valsartan, it is a ARB. ये आपका angiotensin receptor blocker, and this is a neutral endopeptidase or neprilysin inhibitor. आप इसको neprilysin inhibitor simple. It is a neprilysin inhibitor. इसका ये AR और इसका ये, this combination, it is available. ARNI, as a name of ARNI. AR is angiotensin receptor blocker, and this is a neutral endopeptidase. No. Another drug, already I have told, with the in the chronic CHF, once this angiotensin 1, यहाँ पे जो आपका angiotensin 1, once it is, थोड़ा सा इसको little bit let me clean, in a RAS pathway, once angiotensin 2 it is formed, then what will happen with the angiotensin 2? It is going to act on angiotensin 1 receptor, and these receptors, they are also present on the posterior pituitary, where there is a release of ADH. Now this ADH, or another name for ADH is, what is ADH? Or vasopressin. Same thing from the posterior pituitary. Vasopressin, they are going to cause the vasoconstriction, and ADH, it has got the antidiuretic effect. So they are going to increase the volume overload, increase the volume, blood volume. So ये दो effect हो गए, vasoconstrictor and increase the volume overload. So if we give this antagonist, so we can use ADH, antagonist. So we have a drug tolvaptan. So tolvaptan, it is a vasopressin antagonist. Tolvaptan, it is a vasopressin antagonist. So ये क्या करेगा? Now it has got totally opposite. Vasoconstrictor को भी negative and antidiuretic को भी negative. So it is going to inhibit the vasoconstrictor effect, and it is going to inhibit this antidiuretic. So that's all in the drugs for the congestive heart failure. So in the congestive heart failure, the most important question here in this topic is now this one. Mechanism of action of digoxin in CHF. देन डोपामिन इन कार्डियोजेनिक शॉक, वो मैंने आपको बताया. ड्रग्स फॉर द एक्यूट हार्ट फेलियर, ठीक है. देन there is a beta blocker in the congestive heart failure, that can also be asked. Then sometimes you may get the classification of the drugs which we use for the congestive heart failure. Whenever you are going to get the drugs for the अगर आपको classification होती है, so it is given very clearly in the standard textbook of pharmacology. You can refer the Tripathi, you can see the Sharma, ठीक है. तो उसमें क्या है, you have to categorize the drug in two groups. The drugs which are going to give us symptomatic relief and the drugs which are going to improve the survival. जहाँ पे आपने symptomatic relief का दिखना है, वहाँ पे सबसे पहले diuretics, ठीक है. Then inotropic drug, diuretic में आपका furosemide आ जाएगा. Then thiazide also you can write, but mainly we are using the furosemide. Inotropic में आपका the जो sympathomimetic, dopamine, dovitamin, phosphodiesterase inhibitor, इसमें आपका inamrinone, milrinone and levosimendan, ये आपका आ जाएगा. Then cardioglycosides, we have a digoxin. So these are the inotropic. Now the drug which are going to decrease the workload, that is a vasodilator, abinodilator लिखो, arteriolodilator लिखो and a mixed dilator. You write that. So these are the drug which are going to take care of the symptomatic. Then the drug which is going to improve the survival of the beta 1 blocker, okay. Then another group ACE inhibitor, then angiotensin ACE inhibitor, then angiotensin receptor blocker, and the last one is spironolactone. So or aldosterone receptor antagonist. So this way you are supposed to write the classification, and usually they ask classify the drug which we use for the treatment of CHF, and then they can ask the mechanism of action of digoxin. Even toxicity is very important, and hypokalemia, how the hypokalemia it is going to cause the digoxin toxicity, and what is the current status of digoxin. So digoxin, though we do not use it very commonly, once it was a first line drug which was used for the congestive heart failure. Now it is not used as a first line drug, but for the examination point of view, many questions they are asked from the digoxin, like mechanism, current status, its toxicity, its interaction, it's a most common side effect, most common cardiac side effect, okay, and how you are going to treat. So if you have any query in this topic, so you can ask in the suggestion box. You can put your comment in the suggestion box. If you like my video, please subscribe my channel and put up your important suggestion in the comment box.